The Nursing Informatics and Health class at East Tennessee State University assigned the topic of high-rate readmissions for patients with pneumonia and COPD. This presentation was constructed by Tony Henderson, Brianna Edwards, Jill Crumley, Jasmine Goodman, and myself, Amanda Heggie. My name is Amanda Heggie, and I will be discussing the overview of quality safety measures in organizations. Quality of care is a major focus of healthcare reform, and dashboards are emerging as valuable tools for tracking performance measures, clinical and operational performance, and facilitate transparency. A dashboard is a system to track key performance indicators within an organization. Most nurses don't have time to read reports about how their individual unit is progressing. Instead, a dashboard is meant to be designed so that information is easy to read and quick to understand. It provides signals of where things are going well and where there are problems to address. It also assists staff to determine whether or not their unit is meeting their goals. So, think of a quality dashboard as your car's indicating signals that light up on its dashboard. When something is wrong with your car, such as low fuel, oil change is required, or you simply need to service your engine, an indicator symbol lights up on your car's dashboard, notifying you to take action so that your car can continue to run smoothly. Well, this is similar to quality dashboards in the medical field. They provide us with signals that deliver insight and identify areas needing improvement. A quality indicator is a standardized, evidence-based measure of healthcare quality that can be used with readily available administrative data to measure and track clinical performance and outcomes. Quality indicators are what we are measuring, which, for this assignment, would be the readmission rates of pneumonia in patients that have COPD. The purpose of a dashboard at an organizational level is to monitor the facility's overall health. It involves reviewing the organization's mission, vision, and strategic plan to elect the most important goals for the organization to achieve. This dashboard includes data on quality and safety, clinical outcomes, business development, programmatic growth, and academic output. Dashboards at a unit level monitor quality indicators in a specific area or unit of a facility. They are more project-centered to examine the results of specific improvement efforts. These objectives will relate to the outcomes the improvement efforts are trying to produce. This dashboard may include metrics on patient and employee safety, readmissions, how the patient navigated through the organization, as well as many others. Although some indicators are common across all unit dashboards, some units may also choose indicators that pertain to their unique patient population. There are many different specialty areas in each healthcare facility. A hospital may have different wings based on the patient acuity, diagnosis, or reason for visit. Some of these units include outpatient, inpatient, ICU, ER, pediatrics, as well as clinics and surgery. Each may have their own unit-centered and specific indicators they need to improve on, such as the reduction of pressure ulcers, falls, or readmissions. The emergency department may monitor door-to-doctor and door-to-discharge times, whereas pediatric units may have an indicator that focuses on the nurse's IV starting skills. At the organizational level, dashboards can compare the different units. This allows the facility to see which specialty area still lacks improvement that others may have achieved. Data may be collected from discharge surveys, nurse documentation, and patient information obtained upon admission. Discharge surveys can help address the patient's previous experience regarding how they were treated and cared for, if they were properly educated concerning medication administration, at-home limitations, and follow-up appointments. It also allows them to address any concerns that they may have. Nurse documentation includes patient information, while at the facility, such as when procedures occurred and how the patient tolerated it, as well as the medication they received and tasks that the nurse assisted the patient to perform. Upon admission, each patient is asked a set of personal questions, including health history, reason for visit, symptoms, insurance information, along with several others. To construct a dashboard, all data is collected in one spot and reports are generated on a regular basis. If the amount of data being tracked is small, an Excel spreadsheet may meet the need. Larger groups and major medical centers, however, may require a software program that can handle millions of pieces of data per year. This usually requires storing data on a server or cloud-based system. The facility may also have additional staff to manage, organize, and input data. This may be a quality team that collects the data from a built-in system and incorporates the information into a dashboard for each unit and organization.
My name is Tanisa Henderson, and I will be discussing the individual indicator for readmissions of COPD patients with pneumonia. Our quality dashboard is broken down into 4 quarters for the year of 2018. Our goal was 0. In our first quarter, there was 6. The second quarter, there was 3. Third quarter, there was 5. And the fourth quarter, we had 4. This gave a total of 18 readmissions of COPD patients with pneumonia. COPD and pneumonia readmissions are measured as a quality indicator due to high cost of medical care and treatment, reduction of insurance coverage if readmitted within 30 days, the readmissions being linked to several quality measures, from mortality to patient experiences. Pneumonia readmission rates in patients with COPD should be addressed because COPD alone affects 20 million Americans and is one of the most frequently reported comorbid conditions in pneumonia patients. It can cost as much as $49.9 billion annually. COPD causes more than 700,000 hospitalizations, and approximately 20% of patients hospitalized for COPD are readmitted within 30 days. Compared to patients without COPD, pneumonia patients with COPD are likely to have more severe pneumonia, increased number of hospital admissions, and worse outcomes. Pneumonia causes approximately 1 million hospital admissions and more than 50,000 deaths annually, with approximately 19.3% of those million being readmitted. Centers for Medicaid and Medicare Services, or CMS, measures and reimbursement are an issue because in 2010, the Hospital Readmissions Reduction Program was enacted. This required Medicare payments to hospitals with above average readmission rates to be penalized. This reduced Medicare payments by up to 3% for readmissions of congestive heart failure, acute myocardial infarction, pneumonia, and most recently in 2014, COPD was added.
This is Brianna Everts, and I will be discussing 5 evidence-based interventions that will help limit the rate of hospital readmissions due to pneumonia in patients that have COPD as a comorbidity. Patients with COPD are more prone to diseases such as pneumonia due to their weakened respiratory system. The goal with these patients is to control their COPD by preventing exacerbations and avoiding infections. The 5 interventions we came up with are smoking cessation, pharmacologic therapies, vaccinations, pulmonary rehab, and patient education. Smoking cessation can reduce hospital readmissions because abstaining from smoking decreases the risk for respiratory infections. Smoking damages the body's natural ability to respond to bacteria and also decreases respiratory function. The best practices related to smoking cessation include a combination of pharmacotherapy and cessation counseling. Cessation counseling is based off of the 5 A's: ask, advise, assess, assist, and arrange. The nurse starts off by asking questions to obtain information about the patient's smoking habits. After this, they advise the patient to quit smoking. Next, they assess the patient's willingness to quit. If the patient is willing to quit at this point, they then assist the patient with developing a plan to quit and offering resources. Finally, the nurse arranges follow-ups to track the progress. A quit plan typically also involves the use of pharmacotherapy. Studies have found that nicotine replacement therapy combined with varenicline is the best practice to help patients quit smoking. Nicotine replacement therapies include gum, patches, or inhalers with low dose nicotine. The goal with this is to slowly decrease the dose over time until nicotine is no longer needed. All these things combined are proven to increase the rate of smoking cessation. Our next intervention is the use of pharmacologic therapies directly related to the respiratory system. Patients with COPD are generally prescribed corticosteroids in combination with bronchodilators to reduce inflammation and open airways. They are also put on antibiotics to help treat and prevent infections from occurring. The best practice guidelines show that taking antibiotics for 10 days is the most effective treatment plan when dealing with respiratory infections. If a patient's COPD is advanced, they may be prescribed a lower dose antibiotic that's taken daily for a month. The most important thing to teach patients about taking antibiotics is to finish all of their medicine even when they begin to feel better. This helps decrease the likeliness of the infection returning, which directly decreases the likeliness of the patient being readmitted to the hospital. Other therapies, such as mucolytics, can help loosen up the mucus in the lungs and decrease the overall amount of mucus being secreted. This prevents the mucus from building up and staying in the lungs, which is the way that respiratory infections occur. Our third intervention is getting proper vaccinations. Patients with COPD should get both the pneumococcal vaccination and the flu vaccine. The CDC recommends that any patient over the age of 65 or patients who smoke tobacco products should obtain the pneumococcal vaccine. This consists of getting a dose of the PCV13 followed by a dose of PPSV23 at least 1 year later. All patients should receive the flu vaccine once yearly. Both these vaccinations decrease the incidence of respiratory tract infections. Our next intervention is pulmonary rehabilitation. The goal of pulmonary rehab is to improve respiratory function and improve the symptoms relating to COPD. Rehab consists of exercise training, education, and self-management. Guidelines state that rehab should last between 6 and 8 weeks for maximum benefits. Exercise training should be performed twice weekly, and these sessions should consist of endurance, interval, strength, and inspiratory muscle training. Over time, patients show an increase in lung capacity, which leads to a decrease in dyspnea. Also, with the improved respiratory function, patients are able to use their muscles to expel mucus and other foreign bodies more easily, which decreases the likeliness of an infection occurring, therefore, once again, decreasing hospitalizations. Our last intervention goes along with pulmonary rehab, and that is patient education. Patient education has been shown to increase long-term adherence to and health-enhancing behaviors. When combined with regular follow-ups to decrease readmissions due to pneumonia, patients need proper teaching related to infection control, such as hand washing, wound care when applicable, and environmental cleaning. Also, teaching related to medications should be included. This includes things like dosing, side effects, and proper use of inhalers. The key to all these interventions is to continue regular follow-ups on these patients and to make sure that they are continuing to comply with their treatment plan and stay up to date with the new evidence-based practices in order to prevent hospital readmissions.
Hi, my name is Jill Cromley, and I will be discussing about the role of the BSN in readmission of COPD with pneumonia. A BSN has many important roles and responsibilities, including being an active member of the multidisciplinary team and advocating for the patient throughout their experience. They can be a case manager, they can be a collaborator, they can be a patient educator, and they can also be a leader and at the same time a researcher of the team. And to reduce the high rate of COPD patients readmitted with pneumonia, the RN can do a patient education and staff education to minimize the cases. For patient education, RN can teach correct use of incentive spirometer, inhaler spacer, and medication administration to follow the strict treatment of the regimen treatment. Expressing the importance of smoking cessation, propose exercise programs, and encourage daily physical activities. Teach patients how to recognize exacerbation and seek help to avoid worsening of the situation. Encourage fluid. It's very important to teach the patient to drink a lot of fluid when they are in that situation. For staff education, BSN should ensure all labs are performed for accurate diagnosis before antibiotics are administered. We should begin the antibiotic within 4 hours after arrival at the hospital. We should keep the head of bed elevated at 30 degrees to facilitate the breathing of the patient. Provide frequent oral care to reduce bacteria in the mouth. This will really help lessen the bacteria or the infection. And enforce hand washing. We should enforce to do the hand washing prior and after taking care of the patient. And educate on universal precaution and the proper use of protective equipment.
The RN can monitor the impact of change by collecting patient documentation regarding treatment and intervention effectiveness into the electronic health record. This information can be implemented into a dashboard to assist the nurse in determining if the specific indicator has improved. According to Alexander, the facility was able to implement highly specific performance improvement activities and the use of clinical dashboard in ongoing follow-up of the activities. Again, this is Jill Cromley. Thank you.
Hello, my name is Jasmine Goodman. I will be discussing informatics in nursing. Informatics is the integration of healthcare and technology. Technology enhances the nurse's practice by collecting data, the use of electronic medical records, and providing comprehensive care. Implications are reviewing the factors related to poor quality care, discharging early, and failing evidence-based treatment guidelines. Many interventions, such as educating post-discharge care, could reduce readmissions. Informatics can be used to analyze data collected, provide care efficiently and quickly, compare data, and track any problems that occur. Data mining is the process of finding abnormal patterns and correlating with large data to predict outcome. In data mining, a patient's gender, age, type and amount of medications, length of stay, number of other diseases, and total admission costs are examined. In patients readmitted with pneumonia, data mining is relevant because it can help predict readmission rates based on different variables. Based on our dashboard, recommendations for the use of informatics to ensure interventions are effectively preventing readmission rates, including data collections through the use of electronic medical records. Electronic medical records enhance the ability to provide care with full knowledge of previous health history. It can help minimize duplication and promote care coordination among healthcare providers and agencies and aid the development and comparison of performance measures. With the use of computer technology education, it will allow nurses to correctly document patients' information to the electronic device. This documentation allows us to review previous patient hospitalization as well as enable us to verify vaccination, allergies, and previous successful treatments. Adequate knowledge and proper use of EMR systems ensure adequate medication administration, such as antibiotics to treat pneumonia, corticosteroids, and bronchodilators for COPD patients.
My name is Tanisa Henderson, and I will be summarizing the main points of this presentation. You see, you cannot manage what you cannot measure. The role of performance measures is to track variables for results and outcomes. This generates reliable data on the effectiveness and efficiency of the interventions and the achievement of overall objectives. Observing performance deficits are important to enhance quality of care and limit any additional and preventable medical cost. Evidence-based practices are known to improve patient outcomes, decrease the rates of readmissions, and prevent additional complications. The financial implication for hospitals is that pneumonia is responsible for close to 140,000 hospital readmissions per year, costing more than $10 billion in hospital expenditures.